Good morning, and welcome to our August educational call of the Ohio Hospital Association's statewide sepsis initiative. I am James Giuliano, and I serve as Vice President of Quality Programs here at the Ohio Hospital Association. Today's program will further our focus upon the chronicity of sepsis, and joining us on our call today are members of the OHA HIN, the OHA statewide sepsis initiative, the post-acute care community, the Ohio Department of Health representatives, and the Health Services Advisory Group. So we welcome you all to this call. We always begin our calls by revisiting the goal of this statewide initiative, that being to achieve the OHA's board-directed goal of a 30% reduction in sepsis mortality statewide by the fourth quarter of 2018. But before we begin today's session, we would like to address just a few important details. Please know that you will be given an opportunity to type in questions through the chat box feature throughout the presentation. Questions are encouraged, and they will be addressed at the end of the presentation. So you don't need to wait till the end of the presentation to type in any questions or comments that you might have. This presentation is being recorded, and it will be posted on our sepsis webpage, which can be visited at ohiohospitals.org/sepsis. And by clicking on the education link. There you will find all of the previously recorded sessions that do not contain OHA member data. Finally, this program has been approved for 1.0 contact hours of continuing nursing education. If you wish to claim this activity, please be sure to complete the sign-in sheet and the evaluation form and to fax them back to OHA using the fax number listed at the top of the forms. It is imperative that you provide the correct email or postal mailing address to which you wish to receive your certificate of attendance. Our topic for today's call is strategies for enhancing sepsis survivorship. Our commitment to addressing sepsis topics across the continuum of care, again, has led us to today's program, which will focus upon Dr. Prescott's top 8 list of interventions for enhancing sepsis survivorship. A little bit about Dr. Prescott. Dr. Prescott is a board-certified physician with clinical interests in general pulmonary and critical care medicine, with a particular interest in sepsis, acute respiratory distress syndrome, and pneumonia. Her research focuses on understanding the general mechanisms of long-term morbidity in sepsis survivors, improving risk stratification in critical illness, and in developing the science for decision support interventions to guide clinical management during and after critical illness. She has held numerous clinical and academic appointments in pulmonary and critical care medicine. Dr. Prescott has presented extensively on the topic of sepsis and has authored and co-authored numerous articles pertaining to sepsis in peer-reviewed journals and publications. Again, it is my pleasure to welcome back Dr. Hallie Prescott. Dr. Prescott?
Great, thank you for the introduction and thanks for having me again here today. So as you mentioned, I'll be talking about strategies for enhancing sepsis survivorship. There we go. Quickly, disclosures. I've got no relevant financial conflicts of interest. I have funding from NIH and American Thoracic Society Foundation for grants related to post-sepsis survivorship. And also need to tell you that these views don't represent views of U.S. government or the Department of Veteran Affairs. So I will sort of pick up where we left off last time. So as you remember, we talked about all of the different sort of complications and sequelae that people commonly experience after surviving a sepsis hospitalization. And we went over a case study of a patient who had a prolonged hospitalization for sepsis and multi-organ failure, was ultimately discharged to an inpatient rehab facility where she spent several weeks learning how to walk again, and then went home where she still struggled and ultimately retired early. So our conclusions from this last study, we found out that sepsis survivors have increased risk for death. About 1 in 5 will die in the 2 years following sepsis hospitalization, and that seems to be related to lasting effects of sepsis. Over half of patients develop new physical limitations surrounding a sepsis hospitalization, which is significantly higher than people after just a general hospitalization for other causes. Cognitive decline is common. We know that about 15% of patients surviving a sepsis hospitalization have moderate to severe cognitive impairment, and many more likely have subtle or mild cognitive impairments following hospitalization. Anxiety, depression, post-traumatic stress disorder are very common in survivors of sepsis, not necessarily due to the sepsis hospitalization, we don't believe, but is certainly something important to recognize and address to try to help with recovery. And that healthcare use and hospital readmission are very common in this population. The 5 leading causes of hospitalization that are potentially preventable are infection, heart failure exacerbation, kidney failure, COPD exacerbation, and aspiration pneumonitis. And so we'll touch on those more during today's talk. And then several of these are particularly increased after sepsis hospitalization versus, patients surviving similar hospitalizations for other causes. So in particular, risk for infection, kidney failure, aspiration, and cardiovascular events are increased relative to similar survivors of other acute medical illnesses. So what can we do to improve our long-term outcomes and long-term survivorship for patients after a sepsis hospitalization? That's what we'll be talking about today. And so I am going to review this relatively small evidence base for post-hospital interventions for patients surviving sepsis and critical illness. And then I'll talk about what I call like my top 8 list for things that we can do to try to help patients have a better recovery after a sepsis hospitalization. So the first study that I want to draw your attention to is this SMOOTH study, which was published in JAMA last year. This was a randomized controlled trial of they called a primary care-based intervention for patients surviving a sepsis hospitalization, and also who were in the intensive care unit during that hospitalization. This study was done in Germany, and the patients were recruited from 9 different ICUs. It was a well thought out intervention, so the intervention included 3 main components. The first was education for patients and also primary care doctors about sepsis and the common sequelae. Patients also had case management, which was done by critical care nurses who were also trained in sort of outpatient care management. And the case management focused on screening for common symptoms and trying to address them early. Lastly, there was also clinical decision support by an intensivist. So basically that meant that the primary care physicians whose patients were recruited into this trial were given essentially like a pager or direct access to a intensivist that they could call to ask questions about to sort of help them troubleshoot dealing with any problems after the sepsis hospitalization. The primary outcome that they selected for this study was mental health-related quality of life at 6 months. However, they followed many, many outcomes. So there was a total of 32 outcome measures that were measured at both 6 and 12 months. So they found that there was no difference in the primary outcome of mental health at 6 months. And then in terms of the secondary outcomes, so they looked at survival, they looked at quality of life, they looked at a variety of different mental health scales that looked at depression, PTSD, also cognitive function. They looked at a self-assessment of health, healthcare utilization, so doctor visits and also hospital readmissions, and then they looked at functional outcomes. And the vast majority of these outcomes showed no difference between people in the treatment arm versus the control arm, with the exception of functional outcomes. So 5 of these different functional outcome measures actually showed a significant treatment effect favoring the people in the intervention. So people who got this intervention had were better able to complete their activities of daily living at 6 months and 12 months. So these are things like ability to bathe, dress, toilet, transfer out of the bed independently. So those things make a huge difference in terms of people's, day-to-day functioning and whether, family members have to serve as caretakers, whether people need home health care. They also found that people rated their disability lower and had better self-rated physical function at 6 months. They also had less insomnia at 12 months. Because of just the sort of sheer number of outcomes and the fact that the positive outcomes were not seen in what was pre-specified to be the primary outcome, this was considered a negative study, and these positive effects were sort of considered exploratory or hypothesis generating. Nonetheless, the fact that they sort of all clustered around the same type of outcome in terms of functional outcomes, I think that suggests that probably this isn't just random that these outcomes were seen, but probably that this outcome did perhaps help people in terms of their functional and physical recovery after sepsis hospitalization. All right, so that's the only study really that's been done to date to look at rehabilitation specifically of sepsis survivors. But we do have some other studies that looked at rehabilitation in general of people surviving a medical ICU stay for any cause. And the general sort of story here is that improvements have been mostly of small effect, and they haven't necessarily been sustained. So they're often seen early on in the rehabilitation course, but when we look further into 6 months or 12 months, that the difference between treatment arms generally gets smaller. It's also important to note that these have been very small studies. So all of these studies have been fewer than 200 patients, smaller than the study that I just showed to you. But nonetheless, this is kind of the best data that we have to date. So there was a study by Jones et al. In 2003 that randomized people to a self-help rehabilitation manual. So essentially this was directions on how to improve their strength and improve their endurance by working out at home. And they found that people who were randomized to this rehabilitation manual had a faster improvement in their physical function as they rated themselves on this SF-36 scale. The next study was done in 2011, and this randomized people to both a rehabilitation manual, as was done in this earlier study, as well as an 8-week home physical therapy program where they had 3 visits from a physical therapist. And this study found no significant difference from treatment arms. However, there was a recent post-hoc analysis that was done for this study where they sort of changed the way they measured things. So, there was some slight differences in the 2 arms at baseline. And so instead of just measuring the sort of raw outcomes that the patients had, they looked at the percent change or the percent recovery in physical function. And when they did that and when they stratified by how much disability people had at study enrollment, they actually find that there is a positive benefit to the treatment arm. And so that suggests, there's some difficulties in terms of how we design these studies and how we measure recovery. And so at least in this secondary analysis of the study, again, there's suggestion that there is, some small benefits to patients who are have more aggressive or sort of more help in terms of their physical recovery. The next study in 2012 was a very small study. This was just a pilot study. There was only about 40 or 50 people enrolled, and they had a 12-week home-based sort of multifaceted rehabilitation program that included cognitive recovery, physical recovery, and functional recovery. So not merely working on strength, but trying to help people really more with completion of tasks and complex activities at home. And they found that the patients who were enrolled in the treatment had improved executive and physical function. I think it was about 2 months after, actually 3 months after enrollment into this program. The last study we have was an 8-week physical therapy program that was more intensive than some of these other ones. So this was several times a week that they had in-person physical therapy, and the outcome here was anaerobic threshold, which was improved, to a very small degree, but improved significantly at 9 weeks for people randomized to this intervention. But by 6 weeks, there was no difference between the treatment arms, so it wasn't sustained after the program ended. So overall, small studies, not a lot of them, but they do suggest that there are small, at least early improvements in physical function and physical recovery in people who have additional help with their recovery. The next type of studies that have been done have been looking at specialized ICU follow-up clinics and also case management programs in people surviving a general ICU hospitalization. So this is a study by Daly and Douglas. This was a single study, but it was reported in 2 separate publications. They did a, quote, disease management program where they had care coordination, education, family support, and their primary outcome was looking at hospital readmissions, and there was no difference in this outcome. They did find that, when the patients were readmitted, they spent fewer days in the hospital, but for the most part, this was essentially a negative study. There's been 2 studies looking at specialized clinics to try to care for the complex needs of people surviving an ICU stay, and both of those had showed no no difference in the primary outcome or any of the secondary outcomes. However, the main criticisms of both of these studies, I think, is that the ICU follow-up clinics happened rather late. So in this study by Cuthbertson et al., the first time the patients went to the ICU follow-up clinic was 3 months after their hospitalization, which there's a lot that's happening in those first weeks and first few months after hospitalization. And I think it's broadly thought that 3 months is really just too late to sort of start the recovery process or too late to intervene. And so it's not that these clinics are sort of destined to failure, but that we need to, if we're going to do clinics specifically for ICU follow-up, that they need to happen sooner for most patients. All right, so that's really the sort of summary of all of the interventional trials that have been done trying to rehabilitate patients after critical medical illness. There have been a few other observational studies that are helpful and shed some light. This is a study that was done in Taiwan where they have a national healthcare system, so they have complete capture of their entire population. And so they did a study of over 30,000 sepsis survivors, and they matched patients who had been enrolled in a comprehensive rehabilitation program, including physical therapy and occupational therapy, within 90 days of discharge from a sepsis hospitalization. And they did a very complex, essentially matching to patients who were otherwise similar, meaning like similar age, similar chronic comorbidities, similar severity of illness and duration of hospitalization, but who hadn't been enrolled in a rehabilitation program. And they found that people who were enrolled in a rehabilitation program had a significant survival benefit that persisted out to 10 years, so for a long term. And so I think that this, again, there's some limitations, obviously, of observational data, and we can't know for certain if there aren't sort of other unmeasured variables here that are sort of biasing this result, but it's at least some additional data we have that sending our patients to rehabilitation early after sepsis hospitalization does result in long-term benefit to patients. Okay, so interim conclusions, that's the summary of best data we have. Existing studies show small benefits largely in terms of functional outcomes, but that the best practices for enhancing sepsis survivorship have yet to be defined. And so what I will be showing you is my top 8 list for enhancing sepsis survivorship. This is something that I've thought a lot about. I've got several different book chapters, publications, and press under review for talking to these essentially concepts, but again, has the disclosure that these have not necessarily been tested or proven in randomized controlled trials. These are just what I think of as sort of common sense or extrapolating from the data that we do have. So I'm going to present these top 10, and they are not in order of importance. Rather, I'm presenting these in order of time. So I'll present first prevention strategies, things that we can do during the hospital stay to prevent downstream sequelae or complications of sepsis. Then I'll talk about things that we can do around the time of hospital discharge, and then I'll talk about things that we can do after discharge. I think all of these things are important, so this isn't meant to be, again, not meant to be in order of priority. So first, we'll talk about 3 different things that we can do in the hospital to prevent downstream sequelae and downstream complications of sepsis. So as I'm sure all your hospitals are working on, timely and effective treatment of sepsis is critically important. And by this, I mean time to broad spectrum antibiotics, early fluid for people who have low blood pressure or an elevated abnormal lactate, and then source control of the infection. And we have good evidence. So there's been a debate for a long time about how necessary, how critically important is it to get antibiotics into our patients early, because there's always been concerns that, that may lead to treating people who don't have sepsis, that may breed antibiotic resistance, this may lead to problems. But just in this past year, we've had 2 important publications that have come out that are the largest publications to date and have had the best ability to, again, adjust for potential confounding. And both of them show a measurable increase in mortality with even hourly delays in antibiotics and hourly delays in what we call the 3-hour bundle. And so even people who get this treatment within 1 hour do better than people who get this within 2 hours. So I think that it's important to do our best to roll this out in all hospitals to try to get antibiotics and fluid into people as early as possible, recognizing that it's true, we may treat some people who we ultimately end up finding out a few hours later actually probably have something else besides sepsis. But I think that that's okay and that the benefits are justified. and that if we give a single dose of antibiotics, decide on an ultimate diagnosis of something else, we can stop that treatment later, but that we can't risk delaying on treatment of sepsis, particularly people who already have organ dysfunction present. So we don't have data to prove that this results in fewer downstream sequelae, but it certainly would make sense that the earlier you halt sepsis and prevent its progression, that you're also going to have fewer downstream sequelae. And I'm working on some projects right now trying to look at not just these early outcomes, but whether this time to treatment early is associated with better long-term outcomes. And so I suspect we'll have more data to support that going forward. Other data we have, so I showed you those 2 studies that indicate that time to antibiotics and time to 3-hour bundle completion is associated with lower in-hospital mortality. We also have evidence that system-wide quality improvement projects targeting these elements are also associated with reduced mortality. So this first study looked at a rollout of a sepsis bundle at the Intermountain Healthcare System in Utah, and the second one looks at the rollout of a sepsis QI program at the Kaiser Permanente hospitals, and both of them show that as they improved the delivery of early sepsis treatment, they had lower mortality and fewer need for sort of later downstream treatment for severe sepsis complications. So they found that if they treat them early, shock resolved, and they were sort of no longer eligible for later bundle elements because things had been turned around quickly. So I think that this is more good evidence that doing this is the right thing to do. Okay. Next thing we can do in the hospital is trying to avoid the complications of being hospitalized. This is the ABCDEF bundle, which is a bundle of best practices for patients who are on mechanical ventilation, and the sort of big idea behind this is just trying to get people off the ventilator sooner so that we can avoid doing any complications to them while they're in the hospital. So the first bundle element here is to assess and treat pain with a validated pain scale, because we know that treating people's pain while they're on mechanical ventilation often allows us to keep them awake better. So if patient's pain is well controlled, they often don't actually need to have sedative medications like propofol, and so we can keep people awake. The next element here is to do both a spontaneous awakening trial and a spontaneous breathing trial every day that the patient is eligible for this, to try to get them off the ventilator as soon as possible. Next element is choice of sedation and analgesia, which speaks to trying to limit the sedation that people have. And when the people do require sedation, trying to target a lighter sedation goal, not keeping people deeply sedated, but just lightly sedated and comfortable, but not asleep. And then trying to avoid benzodiazepines and preferentially using things like propofol and dexmedetomidine. D is delirium prevention and screening. We know that the duration of delirium is one of the things in the hospital that's associated with increased long-term outcomes, and we need to do our best to screen for this and do everything we can to sort of promote an environment that prevents the development of delirium, because we don't have great treatments for it once it develops. E is early mobility, which I'll talk about a little bit more in the next point, but it's important to try to get our patients up and even walking, even while on mechanical ventilation. And F is family engagement empowerment, trying to involve families during the ICU rounds so that they're better aware of what's happening and better able to care for patients after they leave the hospital. So we have good evidence that this ABCDEF bundle, or at least components of it, are critically important to long-term outcomes. So this study by Tim Gerard in The Lancet in 2008 tested the combined SAT and daily SBT for patients compared to usual care, where these didn't happen as consistently, or at least didn't happen timed together at the same time. And the number needed to treat to save one life at 1 year was 7 patients. So this is something I always stress to my teams in the ICU, is that we spend a lot of time thinking about very sort of like advanced therapies for things like ARDS and advanced medications. But the simple things like doing routine best care, awakening our patients every day and having them on a breathing trial, we sometimes forget to pay attention to that. And this is associated with a much bigger survival benefit than a lot of the things that we focus on in ICU rounds. And so it's important to make sure that, again, like in our ICU, we have systems and processes in place, and that this is a key focus on rounds, is making sure that we're getting our patients up and testing their readiness to get off the ventilator as soon as possible. All right, so next is early mobility. This is included in the bundle I just talked about, but I think is important enough that it deserves its own place on this top 8 list. Early mobility, the goal should be ambulation on mechanical ventilation if possible, and this should be initiated again as early as possible. This is why it's one of the reasons it's important to keep our patients awake enough, is so that they are able to participate in early mobility. So the good evidence we have for this is this trial by Schweikert, also in Lancet in 2009, that found that people that were randomized to this early mobility intervention had significantly higher likelihood of having a return to independent physical function at the time of hospital discharge compared to patients who got usual care, where they didn't get as much physical therapy, or physical therapy was delayed until after they had come off the ventilator. We also have data, which I haven't included here, but there's also studies showing that patients who are involved in early mobilization and are doing physical therapy beyond simple passive range of motion have lower rates of delirium in the ICU. So it seems that giving our patients something to do, something to channel their energy to, decreases the development of delirium. So that's another benefit besides just maintaining the strength of patients. Okay, so those are the 3 things to do in the hospital. Early treatment of sepsis, trying to get people fluids and antibiotics as soon as possible, trying to prevent any treatment-related harms by consistently doing the ABCDEF bundle, and focusing on getting our patients awake enough so that they can participate in physical therapy and maintain their strength during the hospitalization. All right, so now I'm going to talk about things to focus on at hospital discharge. And one of the most important things I think to focus on at discharge is the medications that the patient is going home on. We've got very good evidence that medications frequently get stopped or started erroneously at the hospital discharge. So chronic medications, things like Synthroid, gastric acid suppression, anticoagulants, and statins, things that the patient is meant to take indefinitely, are often stopped for some reason during the hospital stay, and then people forget to put those back on. Likewise, acute medications are frequently started, things like antipsychotics for agitated delirium, antidepressants, benzodiazepines, gastric acid suppressants, and inhalers. And these things may not be necessary after the patient goes home, but they often just remain on the medication list. So these are very important. These are not certainly unique to sepsis. This is a problem sort of throughout hospital care, is making sure that patients get on the right medications at discharge. But patients with sepsis have longer and more severe hospitalizations, and so they have a higher rate of these types of problems where the medications get stopped or started erroneously. The other thing I think is that beyond simply getting the medication list correct, meaning making sure that you've reconciled the medication and stopped the temporary meds and gotten them back on their home chronic meds, is we need to think about the medication dosages for patients going home after sepsis. So oftentimes, people with septic shock, blood pressure may still be running relatively lower than normal, even at the time of hospital discharge. And so it may not be possible to put on all the chronic cardiac medications or beta blockers that the patient's used to taking. And their blood pressure may continue to rise as they recover in the weeks after sepsis hospitalization. Likewise, people often lose a lot of weight. They may still have some mild kidney dysfunction. So cardiac medications, blood pressure medications, diuretics, and renally cleared medications, all of those need to be adjusted and reassessed frequently during the discharge process. So I think that as we focus more on reconciling getting the right list, we haven't really put a lot of attention in terms of getting the medications correct. And I think that that's something that needs to be explicitly addressed at ICU discharge, at hospital discharge, and then again at the time of primary care follow-up. Okay. The next thing that we need to do at hospital discharge is preparing our patients for what to expect. This is a survey, a question that was given to patients at the Michigan Keystone ICU conference. So these are people who are already in a quality improvement collaborative. So they're already people who are very invested in trying to give the best care, so sort of a self-selected population. And they were asked, do medical teams in your ICU have formal discussions with patients or family members regarding challenges or changes to their lives after ICU discharge? And about a third of the respondents said almost never, or only for the very sickest patients. Third said it varies widely depending on practitioners, and a third said, oh yeah, we do have those conversations with many or most patients. Given that this is self-report of a selected population, probably in real life, you know, the numbers are actually worse than this, and that we don't do a great job of telling patients about what to expect after hospital discharge. And I'll admit that you know, it's a hard conversation to have, right? Oftentimes, if you work in an ICU, the last time you see a patient is when they're leaving the ICU and going to the floor, and so it feels like a real downer to say, oh gosh, you know, it's great, you're getting better, you know, you're leaving the ICU, but oh hey, you may have a lot of problems after you leave the ICU and after you leave the hospital. So we need to get better at sort of having these difficult conversations. Unfortunately, I think that we have increasing resources to help have these conversations and to help educate patients on what to expect. So I'm going to show you guys this website. This is from the Society of Critical Care Medicine. There's a Thrive initiative that is sort of a task force within SCCM that's trying to promote recovery after critical illness. And this task force has made several whiteboard videos that are short. So these are like 2 to 4 minutes, and they're geared towards patients, and they talk about things like what to expect after hospital discharge, and what common problems patients have. There's also a video on sort of wellness, including just sort of physical, emotional, spiritual wellness after the ICU, which is, again, another thing that physicians don't do a great job talking to patients about. So this is a nice resource to give patients during the ICU, during the hospital, to sort of spur questions, but also something that patients can watch after they leave the hospital as well. Other resources, this is a patient education handout that we use at our hospital that is what patients need to know about post-intensive care syndrome. So again, talks about common challenges, common problems people have after critical illness. And it's something that's, you know, easily available on the web and can be adapted and used at your hospital as well. So I think a lot of patients, a sort of frequent story I hear from patients is that they assumed that as long as they got through the hospitalization or as long as they got through the ICU that they'd be fine. And they didn't expect to have all the challenges that they have. And so they really felt just like a failure that they had all these problems, and they didn't realize how common this is. So I think that if we prepare patients about what to expect, it will help mentally for people to realize that they're not alone. And also, patients will know what to do. I frequently have patients come back to my clinic and tell me, like, gosh, I got home and I felt so weak and I felt short of breath. It was hard for me to do anything, so I just didn't do anything. I thought I will just wait for myself to get better. Not recognizing that you have to push yourself through this initial discomfort, that you have to, you know, push yourself to regain your strength, to walk a little bit more each day, even though it's a challenge. They worry that they're somehow doing harm to themselves by moving when they have this new weakness or new shortness of breath. Okay, here's a few other resources. So more websites that patients can use specifically for post-sepsis syndrome. Sepsis Alliance has good resources, including hundreds of patient profiles that can be searched by keywords, so patients can find people who may have had a similar hospitalization as them, which I think provides a lot of comfort. People can also share their stories, which is also comforting as well. And then in terms of post-critical illness more generally, there's a couple websites in the UK that are quite helpful. Health Talk has video profiles of patients who survived critical illness, as well as many articles geared towards patients about understanding critical illness and recovery from critical illness. And then ICU Steps is a website that includes a lot of informational handouts that talk about the ICU. So it explains, like, what is a ventilator, what is dialysis, what is a tracheostomy, these terms that patients and families may hear but not fully understand what they mean. And then it also talks about common critical illnesses. And so these are useful pamphlets to have in your ICU or to give to patients at discharge so they have a better understanding of their illness. All right. So those are the things to focus on at discharge, I think, medications, and then counseling patients about what to expect after they leave the hospitalization so it doesn't come as a shock and so that they don't respond to their new weakness or new physical limitations by just sitting and waiting around to get better, because that's not a good recipe for recovery. Okay, so then here are things that we can focus on after discharge. So focusing on the big five. And by this, I mean the common and potentially preventable or potentially treatable reasons that people come back to the hospital early after sepsis hospitalization. So I showed this figure to you last time, which is the top 10 reasons that people come back to the hospital after sepsis. And the big five are the 5 things that account for the bulk of the readmissions and that are potentially treatable or preventable to avoid the readmission. So the most common thing by far and away that brings people back to the hospital after sepsis is another bout of infection. Next most common is a heart failure exacerbation, kidney failure, COPD exacerbation, and aspiration pneumonitis. So for each of these, I think that there are specific things that we can try to do to prevent hospital readmission. So for infections, sepsis hospitalization, and any hospitalization is an ideal time to confirm and update vaccines. And then we do want to counsel patients, particularly after sepsis hospitalization, that they remain at high risk for recurrent infection and recurrent sepsis. Primary care physicians should screen for signs and symptoms of infection, and then certainly have a lower threshold to do additional diagnostic workup, to treat with antibiotics, and to have an early follow-up. So these are the kind of patients, if they're having fevers, you know, in the week after sepsis or a new cough, we want to get a chest x-ray, we want to start antibiotics, we want to follow them up a few days later because they are at high risk for having another bout of infection. And one of the reasons for this is that you know, people have a dysregulated immune response during sepsis, and oftentimes their immune system is still not working properly in the weeks and months after sepsis hospitalization. So increasingly we recognize people have what's called a sepsis-induced immunopathy, or sort of abnormal function of their immune system that sets them up for further infections. And there's currently studies going on trying to test various different medications to try to boost the immune system, but nothing as sort of, you know, ready for prime time. But in the future, we may have medications to try to specifically boost people's immune system in the post-sepsis setting. Right now, we're left with vaccines, counseling, and you know, quick and prompt treatment of any signs and symptoms of infection in the post-hospital setting. For CHF exacerbation, it's important to, again, reconcile and titrate medications. So frequently I have people who are on diuretics, beta blockers, ACE inhibitors. They are not ready to be resumed at the time of ICU discharge, and perhaps not even at hospital discharge. So these things need to be carefully adjusted as the patient leaves the hospital. You need to consider that the patient's weight may have changed, frequently declines following critical illness. People may have subtle differences in their kidney function, which causes them to metabolize medications differently. They may have developed decreased cardiac function as a result of sepsis. So sepsis-induced cardiomyopathy is fairly common, and we don't know exactly how long it takes people's hearts to recover. So I would say that this is a period of sort of labile physiology, and it's important to just recognize that we're not merely reconciling medications, but we also need to sort of think about all these different things that are in flux and titrate the medications carefully during the post-hospital setting. Acute renal failure is another common thing and is specifically elevated in sepsis survivors, about 3-fold relative to people surviving hospitalizations for other causes. Again, medication reconciliation and titration, I think, is important here to think about whether there's any medications that are being cleared by the kidneys that we need to adjust and decrease so that we don't contribute to further kidney damage. The other thing is, I think it's probably worthwhile to follow lab work for at least a few weeks in patients who had kidney failure during the hospitalization, just to ensure that this doesn't relapse, because kidney failure, again, like is the 4th most common reason that people get readmitted to the hospital. Okay. Next thing, COPD exacerbation. I don't think this is necessarily increased in sepsis survivors, but it's just simply a very common reason for people to be rehospitalized, and so is a common reason that people are rehospitalized after sepsis. So this should be, as it's a good opportunity to update and check vaccines, it's a good time to update and ensure that the patient is on good treatment for COPD. So if they have more severe lung dysfunction, they should be on controller inhalers and not merely as needed albuterol. The other thing I think is important to check here is that the patient is not on medications that suppress their respiration. So many patients may be on benzodiazepines or narcotics, and due to sort of changes that happen, sort of just general weakness or declines in their kidney function, they may be more sensitive to these medications after sepsis. And so we may need to down titrate chronic narcotics and chronic benzodiazepines that patients are on after a sepsis hospitalization, and do our best not to start these medications in patients after a sepsis hospitalization. The last thing is aspiration pneumonitis, the 10th most common reason that people get readmitted. For this, I would say we don't have like a strong algorithm at this point to follow in terms of who should get checked. So I say that anybody who has got symptoms of swallowing dysfunction, people who are particularly weak, people with new cognitive impairment, and or patients who have recurrent pneumonia, all 4 of those things are triggers for me to consider a formal evaluation by a speech-language pathologist to do a video swallow study. It would be nice if the only thing we had to screen for was like sort of perceived swallowing dysfunction, but people can have silent aspiration where they don't necessarily feel that they're having difficulty swallowing. They're not coughing after meals because they may have decreased sensation as well. So these other things, weakness, cognitive impairment, and recurrent pneumonia are all, I think, tip-offs or reasons to consider having the patient seen by a speech-language pathologist for further evaluation to determine whether they need any behavioral modifications, dietary modifications, or should be avoiding oral intake for a while. Okay, so the next thing, after trying to think about what are the most common reasons that people come back to the hospital, is empowering patients to help each other. This Thrive initiative at SCCM has also developed a network of peer support groups. There's about 17 hospitals around the country that have in-person support groups for people following the ICU. So many hospitals still do not have these, but fortunately there are online resources. So there are now weekly virtual support groups. And here's the telephone information and also the video information. And so this is something that patients can be referred to. And some patients find this very, very, very helpful, just to have someone to talk to about what they're experiencing, to hear from people who have been through it before and are now 3, 6 months, a year out from their sepsis, hospitalization, or critical illness. There's also a Facebook group. This is a closed group, but patients can search for the name of this group, Thrive for ICU Patients and Families, and they can request to join. And this is essentially a chat room for patients who have survived critical illness. So this is a great resource to provide patients more support after their hospitalization. The last thing is to increase function. So I always tell my patients when they come back to see me, use it or lose it. So it's important to screen for new functional impairments at the time of hospital discharge and also at the first outpatient follow-up. So things specifically to screen for limitations and activities of daily living. And then for people who are able to complete their activities of daily living, they still may have decreased endurance or decreased stamina as a result of their ICU or stay. And so things like 6-minute walk test or a timed up and go test are helpful to try to determine if people have new significant limitations. And then if they do, we want to address them. And here I try to figure out what's the best way to address this. So some patients are extremely motivated and they get up and they walk every day, they keep track of how much they do, and they build up over time. Those patients generally do well on their own, and so don't necessarily be referred anywhere. They just need to be encouraged to do exactly what they're doing. There's other patients who go home and they're afraid. They're afraid that they are weak, they're afraid that they're short of breath, and they're afraid that it's hurting them to move. And these are the patients that should be referred somewhere. So if they're particularly weak, cannot do activities of daily living, can't dress themselves, can't bathe themselves, can't transfer, these patients need physical therapy or occupational therapy or both. People who are stronger, they're able to do their activities of daily living, they're just feeling that they're doing everything a lot slower or a lot weaker than they used to. Those people I'll look to refer to cardiac or pulmonary rehab. So I think, so one of the challenges I think of a lot of the studies that were negative is that they didn't necessarily try to identify where the patients were in the spectrum. They sort of just referred them all to a home exercise program, or they referred them all to a, self-help rehabilitation manual. And I think that doesn't make sense clinically to give people all the same intervention. So I try to figure out where the people fall on the spectrum and refer them to the thing that I think is going to be the most helpful for them. All right, so that is our top 8 list for enhancing survivorship. Again, the first 3 things are to be done in the hospital, things to think about at discharge, and then what to focus on during the early outpatient follow-up. I've got just 2 more things to keep in mind. So I will say that there are patients who are declining for a long time prior to sepsis hospitalization, and then they get significantly weaker or develop new cognitive impairment. They continue to decline during the sepsis hospitalization. There are people like this for whom it would be appropriate to talk about palliation, to try to focus on symptoms alone and recognize actually that this sepsis hospitalization is part of the dying process. So this is something as well to recognize, that there are people for whom sepsis is not sort of an acute weakness or an acute problem, but really is just part of a trajectory that's been going on for months and years prior to the hospitalization. Other things I think is important to keep in mind that I see a lot is to be wary of what I'm calling the kitchen sink approach. So as there's been a lot of focus recently on hospital readmissions and a lot of efforts to prevent readmissions, I find that one of the approaches that people take often is to sort of identify all the problems or all the potential problems that the patients may have and refer them to somebody to help each and every single one of those problems, right? So you can imagine people can get referred to a whole lot of different places after a sepsis hospitalization, and that this leads the patient to be overwhelmed and exhausted. So I like to think about this cumulative complexity model, which was a model that was presented in this systematic review published a couple years ago that looked at interventions to prevent hospital readmissions. And they conceptualize here the patient experience as this balance between workload and capacity. So workload is just the work of being a patient. This is the effort to understand the care plan, the effort to understand their medications, to understand when they're supposed to go to follow-up, what studies they're supposed to be doing to get to those visits, and to enact the care plan. And then capacity is essentially the quality and the availability of resources to carry out being a patient. So you can imagine if you have a very helpful and supportive spouse or family, that's great. You're going to be more able to carry out these care plans. If you are at a healthcare system that tries to, put all of your appointments at the same building and on the same day, that's very helpful as well. But unfortunately, a lot of times when we give follow-up to patients after the hospital, that we just, add more and more and more things to their list, and this is stressful to the patient. And so I often find that patients are not able to enact this care plan because the workload is too much. They do not have the capacity to do it, especially when they have new weakness, they have new cognitive impairment, they're confused, they don't understand the plan. And so what often happens, I find in these situations, is that instead of saying, oh gosh, I can't do that, patients will just decide that they can't do it, and they'll just go to like some of the follow-ups. So they'll go to 3 of their 10 appointments, and they don't always do a good job prioritizing. So they go to 3 appointments that are probably the least important and miss some critical points in terms of their follow-up plan. So I think it's important to recognize that they can't do everything, that we need to pick out what is going to be the biggest problem, what is the most important follow-up, and start with that, and then to reassess and to add more things over time, but not to try to overburden our patients by having them follow up with too many people, too many specialists, too many studies, and too many tests after the hospitalization. So here we go, top 8 list again, and then my other 2 sort of final points to sort of round out an even 10 is to consider a palliative care approach for certain patients and to avoid kitchen sink. And with that, we've got about 12 minutes left, and I'm happy to take questions.
Well, thank you so much, Dr. Prescott, for that very, very informative overview of what can be done from really 3 perspectives. I mean, we heard you talk a little bit about prevention that can occur during the hospital stay. We heard you talk about interventions at the point of hospital discharge. And finally, those things that can be done after the point of discharge. And with respect to the preventative measures that you mentioned, Dr. Prescott, you mentioned the importance of turnaround time studies that are system-wide. And I kind of wondered from that, what comes to mind is the order to broad-spectrum antibiotic administration turnaround time. You referenced the trend with delays for every hour of delay. Are there other clinical indicators for turnaround that are significant in the prevention arena, other than for broad-spectrum antibiotic administration?
Yeah, so I think that certainly the thing that has the most data is broad spectrum antibiotics. Fluids in that New England Journal of Medicine study that I showed was sort of a little bit like on the fence. So in the primary analysis in that study, it didn't show a significant effect, but in a variety of the sensitivity analyses, it did. And so I take that to mean that, yes, it has an effect, but it's not as strong. And so depending on sort of how we ran the analysis different ways, sometimes you see it and sometimes you don't. And so I think it's important, but it's not quite as important as antibiotics, which are the most important thing. The bundle of care was important, and so that also includes a lactate. And I think the lactate is helpful, not because, like, you know, just the lactate itself isn't going to improve an outcome, but it triggers people to recognize if patients have under resuscitation. So if the lactate is very high, this triggers people to recognize and sort of closely follow a patient. And oftentimes, people can have a high lactate that you didn't necessarily expect. So, for example, in that Kaiser study, they checked a lactate on every single patient who had cultures done in the ED. And they found that a large number of patients had a lactate that was, quote, intermediate, so 2 to 4. And traditionally, we had generally done fluid resuscitation only for people with low blood pressure or a lactate greater than 4. But they rolled out fluid resuscitation for all people with intermediate lactate, of 2 to 4, including people who had end-stage renal disease or heart failure, people who we may normally be a little bit hesitant to give that fluid to. And they found a significant mortality reduction when they did this, and that the bulk of the mortality reduction was really actually explained by people with heart failure and end-stage renal disease, the people who we normally might not give fluid to. So I think that lactate and fluids are the other important things. Time to antibiotics is still the single most important thing.
Thank you very much. You also mentioned at the point of hospital discharge the very crucial need to pay attention to not only the right medication list for med-rec, but also for the proper dosage. And, you know, one question that has surfaced is, with multiple physicians managing CHF readmissions or CHF admissions post-sepsis, often med-rec is a challenge, you would agree.
Yeah.
And so one of the questions that has surfaced is, what strategies are helpful in addressing the change in glomerular filtration rate or ejection fraction or any other pertinent indicators for a change in dosing that would kind of bubble up to the top?
Yeah, this is exactly what you're saying. This is a hard challenge of what to do. I think that it's helpful to sort of flag medications that are a work in progress. So there's sort of certain things like Synthroid, probably it's just like going to be there for a long period of time. It's not going to be needed to be titrated frequently. You know, people who have been on antidepressant forever, that's probably not going to need to be titrated around the time of sepsis. But there's other medications that are more likely to need to be titrated. And so I think it's helpful to flag for patients, like this one needs to be titrated, and to flag for other providers too. So things like Lasix, ACE inhibitors, beta blockers are common medications that people are on and that the dosages might need to be changed. So like I saw a patient recently who followed up with me who had come in and was volume overloaded during their hospitalization and got started on 40 of Lasix. I saw him, you know, within a week of hospital discharge, and he was hypotensive and had an elevated creatinine, and clearly it was too much. And so I cut the medication in half, and then sent a message to his primary care physician who was seeing him the following week and said, you know, I did this, it's an active work in progress, please reassess at the next visit. And they actually then further titrated down, you know, so we went from 40 a day to 20 a day to 20 every other day, and then that's what he ended up staying on. And so I think I don't know that that's the world's best solution, but that's what I've tried to do, is flag to patients, this is a temporary thing, you know, this dose is going to need to be changed a lot so that they're aware. And I tell the patient, make sure that when you see your primary care doctor next week that you readdress this medication. And then I, you know, send a letter or message to the next person who's going to see him and say, I changed this, it's a work in progress, please, you know, at your visit, reassess this as well.
Thank you. Our next question is, how do you suggest engaging providers who may be seeing sepsis survivors in follow-up but are unaware of the longer-term morbidity of sepsis?
Yeah, I think, right, so a lot of medical practice is pretty siloed. And so I think that, you know, I go to a lot of ICU conferences and talk about the sequelae of, like basically preach to the choir. And so I think that that's something that's important for us to do, is to, I guess, me to do, is to reach out to people, you know, in other fields to try to talk about these issues. So I gave grand rounds on enhancing sepsis survivorship at University of Michigan last year. And so that was like one opportunity where I tried to talk to people really outside of my silo of critical care. And I had a variety of different primary care physicians email me after that and sort of ask follow-up questions about, you know, things that they can do. And so that's what I've tried to do. But I think that everybody needs to try to do that. I mean, so I think, you know, talking to patients so that they're aware of it, they can then go back and tell their, you know, primary care doctors, but that physicians should take any opportunity they can to try to reach outside of their silo to raise awareness, because I think that this is increasingly, you know, a common problem. And I sort of mentioned, but I have several different papers and press where I'm trying to do that and publish outside of critical care silos to raise awareness in primary care and general internal medicine fields.
Thank you. Our next question is, what do you offer to patients suffering from cognitive dysfunction after sepsis in the ICU setting?
Yeah, I mean, this is a great question. I mean, so the study by Jim Jackson was super promising and did show improved cognitive function, but it was a tiny study that was, you know, just a pilot study. And so I understand, you know, that they're doing more work looking at early cognitive rehab in the ICU and post-hospital cognitive rehab, but we don't have great studies, and I don't know that we have really even great availability. So the thing that I try to do is to, you know, refer people to occupational therapy that focuses a little more on sort of completing tasks, and not just sort of physical strength. But I would say that that's a big challenge and a big unmet need at this point. You know, I sort of, again, will take the use it or lose it strategy and try to tell people to, you know, use their brain as well and try to do things like crossword puzzles and reading, for lack of better sort of suggestions. But I think that we do need more than that for patients. So beyond occupational therapy and using your brain. And I think that there are more studies ongoing trying to develop specific, you know, rehabilitation type programs for cognitive dysfunction.
Thank you. The top 8 to 10 list that you brought to us today, there's a question of whether or not these pertain exclusively to critical care settings, or do you feel that they apply to all med-surg admissions for sepsis as well?
Yeah, I would say that these are, you know, general. I would say that, I mean, some of them are more specific to critical care. So timely and effective treatment, I think, applies to anybody with sepsis. Avoidance of iatrogenic harms, I think, for the most part applies to everybody, although obviously like spontaneous awakening trials and spontaneous breathing trials apply only to people in the ICU. But things like delirium screen and early mobility, I think, are hugely important for all patients with sepsis and actually might get overlooked more on the floor. So there has been a big push to have more mobility in the ICU, but there hasn't been as much push to have more mobility on the wards, and that's probably a missed opportunity. And I think delirium, again, is one of those things that the profile has been raised in the ICU recently. But unless we're actually screening people for ICU, for example, with like a CAM ICU, we don't necessarily know. I mean, there's a lot of people who have hypoactive delirium where it's not immediately obvious to providers that delirium is present. And it's important to identify this so that then you can do everything in your power to make sure that we can resolve delirium by doing things like, if they're at this point more stable, stopping vital signs or doing them less frequently at night, turning the lights off, limiting noise. I mean, honestly, doing all the things that we should do to try to eliminate all the environmental factors that can contribute to delirium. Let's see, other things, preparing people about what to expect. I think that's huge for everyone, right? I mean, so there's been a variety of qualitative studies that have looked at survivors of sepsis, and one study called people after a sepsis hospitalization to like do these telephone interviews with them, and like half the people they contacted had no idea they were hospitalized with sepsis. They just knew they were hospitalized. So again, clearly we could do a better job of telling people that they had sepsis, what sepsis is and what are common sequelae. Big 5 causes of readmission, that applies to everyone. Peer support, everyone. And promote functional recovery, again, applies to everyone, and just depends on how severe the limitations are to figure out what the right type of support is. Yeah.
Thank you. And as we approach the end of our session here, we have one last question dealing with the issue of mobility that you stressed to us today, and that is transferring to a jerry chair or a recliner while intubated considered mobilizing a patient, or is it strictly exclusively referring to ambulation?
Oh, no, I think getting up to a chair is a good first start for sure. Yeah. I mean, there's people, I mean, we want to get people up and walking. We can't do that with everybody. Even sitting up requires, you know, it uses muscles more than just laying flat in the bed. So absolutely, that's on the spectrum of getting people up and moving.
Well, thank you so much, Dr. Prescott, for your presentation, your slides, and for sharing all of the resources with us today. And we would like to thank you for joining us, to all of you who are on the line. And as a reminder, our next call will be held on Wednesday, September 13th, which is a different date than you might have imagined, being it is the second Wednesday of the month instead of the third Wednesday of the month. So Wednesday, September 13th, 11:30 a.m. Eastern Standard Time, where we will hear from the leadership of St. Joseph Hospital in Orange, California, including Dr. Andre Vovan, a 2017 honoree of the Sepsis Alliance. Their presentation will provide an overview of a program they developed establishing sepsis resource nurses throughout their health system. So at this time, it is with great honor that I again thank Dr. Prescott for joining us over the last 2 months with this series on chronicity. There are a number of resources that we have available, and as always, these sessions that have been recorded will be available on our website. So thank you, Dr. Prescott. Thank you all of you for joining us today, and I wish you all a great day.